High Stress Emergency Medicine Residence Program.
Thank you. So thanks everyone, and we're very excited to be here. Actually, we're sort of showing this type of presentation for the first time because this is a very novel project that we are trying out in the emergency medicine program. So just before we're going to start, I'm just going to quickly introduce each of us. My name is Joel Turner, and I'm an emergency medicine specialist working at the Jewish General Hospital in McGill. And I am the residency program director of the Royal College Emergency Medicine Program, which for those who may or may not know, is a specialty program after medical school. It's a 5-year program to become an emergency medicine specialist in Canada. And then I'm just going to have the residents introduce themselves.
So I'm Rohit Mohindra. I'm a second-year resident in the emergency medicine program. I'm also the Canadian Journal of Emergency Medicine resident editor and the social media editor.
My name is Martin. I'm also in the second year at our residency program. One of the things I'm interested in is looking across Canada at the residents. How many of the residents are actually using social media? How many residents are using iPads, iPhones during their practice? And it's one of the surveys I'm asking across Canada in terms of our residency.
Hi, I'm Wayne Choi, one of the R1s at the emergency medicine program, and I'm the token Asian. No. That said, I also have an IT background. I used to do computer engineering. I used to work for Microsoft.
So just a quick disclosure for myself. Just this year, I was named an Apple Distinguished Educator. For those who don't know, it's a community of educators that is recognized by Apple for using Apple technology to innovate new ways of teaching inside and outside of the classroom. And you'll see is that I'm a big, I guess, a passionate user of Apple products. So just to let you know that that's sort of a bit of a disclosure from myself. So the objectives today will be just to introduce, as we've just done, and then the format of this panel discussion. Talk about a little bit about the challenges of residency teaching and residency training. Introduce the iTunes U project that we've been piloting this year. And then finally, what's really important is obviously to have a panel discussion, have an audience Q&A. And as you guys know from the past few days, there's a live Q&A session as well. But if you guys use Twitter, you can always tweet with the hashtag McGillEM. So just a quick idea of the format. So we're going to talk a bit of background information, introduce the iTunes U project. Oops. Go back there. Get some case examples of the ways that residents actually use the various tools to their disposal, and then of course the QA session. So, a bit of information. The amount of medical information that residents have to learn is quite massive. Whether it's in the emergency room, at the computer, in a simulation session. Whoops, too fast. All right. Whether it's a simulation session for resuscitation, whether it's teaching students or junior learners, or having sessions with the physician staff, the amount of information is massive over the 5 years to learn and to become an emergency specialist. And if you sort of look at all the sources of learning where a resident has to obtain this information, there are various hospitals that each have their own policies and protocols and specific drug formularies, grand rounds where presenters come and present a specialized topic. There's medical simulation, journal club, which is where the residents learn about the updated medical literature. Of course, Twitter and online blogs, which are becoming much, much more prevalent in everyday use. And then online texts and videos are also used. So when a resident has to go and get that information, he has to go and look at all various places, and it gets a little bit disheartening as to, well, where am I supposed to find what information? So if you combine that with the idea that mobile devices are becoming basically commonplace. Almost every single resident, physician, nurse uses a mobile device, whether it's at the bedside, in a classroom, or again to teach students. They're everywhere. If you look at surveys of physicians in the US in last year, in 2012, they just looked, whoops. Here you go. So about 62% of physicians use tablets for professional purposes. 85% of them use their smartphones, and about 3/4 of people use iOS devices. So it's everywhere. So the way to now realize that residency education is changing from this, where a resident will go and look up stuff in paper and textbooks, to having everything on their mobile devices or having access to the internet through their mobile devices. Now, one of the big problems is once you're on a computer or on a mobile device, is you have various logins. If you have a special password to a specific hospital or online books, you have subscriptions that you have to have password protection. So at some time, it just gets so inefficient to be able to access all this information. So that's where the idea of iTunes U came about. And this is a project that I wanted to get started, where iTunes U is basically getting all that information and bringing it to one place and one app onto the iPhone or the iPad. So it's a software platform where teachers can basically create courses and can basically have a course of whether it's a PDF document, a presentation, audio or video, or links to websites or links to iBooks. All that can be placed in one device, in one place, so that the resident no longer has to go out and look for these various informations. So it's become really a one-stop shop for resident education. So the initial phase of this iTunes U project was to look at 4 specific places or areas where residents really learn. So the Journal Club is, as I mentioned, it's a monthly session where the residents review a specific article in emergency medicine to learn about the key areas of the literature. The next one would be the hospital policies and protocols. So like I said, every hospital has their various policies, protocols, drug formularies, and as residents rotate from one hospital to another, it's a little bit disheartening to know, well, what drug can I use for this, and what is the policy for this type of condition. EM procedures, obviously, there are a lot of emergency medicine procedures. A lot of them are invasive. Some of them are not very commonly used, but you need to know when to use them. And a good reminder of how to use them is available on the iTunes course. And then finally, grand rounds presentations. There are lots of visiting speakers who come and present their specialty. Sometimes residents who are on rotations outside of the province or outside the country, they miss those presentations. They want to come back and have access to this. So what we're going to do is we're going to have 6 different cases to show you how, in various areas, the residents can use the iTunes U app to show how they get their information. So the first one is a journal club. So the case here is a 65-year-old man who comes into the emergency room who's had a stroke that started 3.5 hours ago. And it's a very, very controversial topic in emergency medicine, of whether a specific type of medication that, I guess in the lay press is called a clot buster, can be used and will it improve this patient's outcome. It's very controversial from 0 to 3 hours, but now we're trying to push the envelope, and is there any evidence that from 3 hours to 6 hours can we use this drug? And there was an article that was reviewed at a recent journal club to look at that.
And so, as Dr. Turner has said, that all the journal club stuff, all the summaries, all the journals themselves are uploaded on the iTunes U. If we look over to the other screen there, we have our iPad here. So clicking on the journal club one shows us, here's all the articles we've reviewed over the past year. And I remember that, we did at the bottom of the screen, the JC summary template right there. And here's a short summary from back in July that we did. And looking at it, we see that there is a little summary at the bottom line here. The primary outcome failed, meaning there's no consistent improvement benefit to thrombolytics within 6 hours window. So if it was a year ago, I don't really remember. So, I remember doing something on it. You can quickly look back in iTunes U to find the thing that we reviewed.
So that's an example of how the articles will be kept throughout the years, and throughout the 5 years, they will be able to go back and look at the summaries that the residents have done to provide that sort of key evidence-based bottom line information, instead of Googling it and having 100 different articles. I'm not sure where, and I'm sure the source. This is something that is right at their fingertips and can see it within a minute. Okay, the next case. So Wayne, you're doing this case as well, right?
Yeah.
So Wayne just finished in an adult hospital at McGill, where he just saw this patient with a stroke. The very next week, he starts at the Children's Hospital, and he hasn't been to the pediatric hospital in a while. And of course, his first case is he's hearing about a 3-year-old boy who's a known epileptic, who's arriving by ambulance, who's actively seizing. Now, he knows generally what medications are to give to this child, but what are the local drug formulary medications that the Children's Hospital at Montreal can be used to treat this patient? So as this patient is being brought in.
Perfect. And so in Montreal, there's a few different hospitals that we go to, including the Children's Hospital as well as a couple of adult hospitals, and each have their own guidelines. So this one is going to be in the top right, the MUHC policy and guideline, and looking at diagnoses guidelines, down here, status epilepticus chart, it has a flow chart on telling us, hey, what exactly medications they have at this particular hospital and what are their policies on this specific type of disease. And I see that in the third point down right here. Well, that's really big. Midazolam at 0.15 milligrams per kilogram by IV or IM. And now I know and don't have to look it up on the computer or look it up on a paper-based book of some sort.
The main thing is that even on our drug formulary app, there are a list of medications that can be used, but this specific hospital and the nurses know what type of medication to go get. They're just waiting for the doctor to be able to tell them, okay, I need midazolam, and is able to be able to access that information right away. Good. Case number 3. So this is now a patient, when a resident becomes a senior resident, their role is not only to learn about diagnosis and management. Their role is also to now manage the department. So flow, if there is an issue, a crisis from an administrative point of view, they have to know the policies and protocols of the hospital. So this is the type of case that we see quite often in the emergency room with a huge amount of overcrowding that occurs. We need to have policies to know where do certain patients go, which services will admit these patients. So this is a 65-year-old alcoholic who comes in with severe abdominal pain. And he's diagnosed with what we call grade D. There's 5 grades of pancreatitis, so D is the second to worst grade of pancreatitis. And even though there's no actual surgery involved, this is a surgical diagnosis. But general surgery, they don't want to admit them, say, look, we're full, they're not going to operate on them, like they can go to medicine. And of course, medicine doesn't have any beds. And this is a common occurrence almost on a daily basis throughout the country, fighting with different services of who's going to take this patient. There's a lot of overcrowding in the emergency room, and so the question is do we have an official policy at the hospital that will mandate what service is going to take this patient? So, you know, Martin?
And like Joel said, policies like this really help emergency department flow. If we know where a patient is going to go upstairs and there's something put in place, we can actually free up one bed in the emergency department so we can see someone. So this is really important for us, especially as learners, because ultimately we're going to be the emergency doctors that are leading the department. So if we have a good handle on where patients are going, where they're going to be admitted, I think it really helps with the flow. It really helps with wait times, which everyone has been hearing about increasing in the media today. So where I'd go for this patient, I'd go, let's say I'm working at the Jewish General, where Dr. Turner works as well. Here we can see the administrative policies. I would go to surgery, and here we have something called the ED surgery admission policy. I can open up this PDF document, and if you look closely, the third point here says all pancreatitis grades C to E are admitted to general surgery. So now we don't have to go through any kind of arguing or discussion where this patient is going. We know where this patient is headed towards, where he needs to be admitted, and we now have an open bed, a free bed to see a new patient in the emergency department.
So this is very key, especially for attending staff and senior residents, because administrators they want to know how to improve the flow, and this is a one-stop place that the residents don't have to argue anymore with any of the consultants. All right, 4th case. So this is a patient who presents with vertigo, and again, for those who are not sure, so vertigo is a type of dizziness where there's a sensation of spinning, very common in middle to later ages. Most of the time it's related to something in the middle ear that's sort of a little bit out of whack. And so there's a specific maneuver that residents can learn to do or can do to help actually cure and treat this condition, and it's called the Epilepsy maneuver. Now, it's not a maneuver that we do every day. It's not like stitching where most residents can do it, with their eyes closed, although I hope they don't do it with their eyes closed.
Only one time.
But it's like, oh, gee, how do I do an Epley maneuver? And again, if you Google Epley maneuver and go to YouTube, there are about, I don't know, 20 different videos. Some are not quite accurate. So the resident's going to wonder, like, how do I know which is accurate, which is right? And some are maybe 10 minutes long. And again, there is no time for a resident to go look up a video that's 10 minutes long. So instead of having the resident Google all these procedures and not sure where the source of this information is, make sure that a high quality video is available, and again is available at on the resident's iPhone or iPad.
So I find this part of using this technology very useful, especially when explaining to patients what we're going to do to them. It's really there's a bit of a technical or kind of communications problem when you're trying to say, okay, this is what I'm going to do in the next 15 seconds. Turn to your right, turn to your left. We're going to turn you on the side of the bed. It kind of gets lost in translation, especially with a patient who's in the emergency department, a bit stressed out because they're spinning dizzy. So what we can do is we can open up common emergency medical procedures. We have a lot of them here, but I'm going to go down to the Epley maneuver, which is what we were talking about. And we can actually open up a video. And what we can do is actually show the patient the maneuver.
To the right side. The head is turned 45 degrees to the right
It's
side.
going to decrease the volume, but...
The patient lies back.
But what we can do is actually show the patient what we will be doing to them so they know what to expect. They're not taken back by anything that's happening. And we also get to review the procedure, review the maneuver in a way that's fast and available to us right at the bedside.
And that's like a 40-second clip. Don't try this at home, okay? So again, it's something that's very easy. There are all sorts of emergency medicine procedures, from something as simple as this to how to crack a chest, in someone who comes in trauma with no pulse. Again, not a common procedure, but it's a potentially life-saving procedure. And the issue is, like, I'm not going to go to Google and learn how to and search that. If I know that I'm doing a trauma rotation or I'm doing a trauma shift, maybe I'm going to just read up on this, and it'll be available on their mobile device. All right, case number 5. So as I mentioned, a lot of times residents go off to either the US or across the country to do electives. And this particular resident went away to do an elective outside of Montreal and missed one of the sort of North America's premier speakers to come and give a grand rounds presentation. So the question is, I missed that presentation. How do I want to be able to see this presentation? And for those residents who were there who say, yeah, this was a very, very good presentation, how do I look at it and review it in the future? So you can have Rohit.
Sure. So I was up late watching the Canadians play, and I didn't really pay attention to Dr. Swadron's lecture.
This was a while ago that he came.
And he gave a pretty good a lecture on cardiac catastrophes that I'd like to review. It's actually a topic that's difficult to find good reading about, and he does a very good job of summarizing it. So the video is available. I'm sitting on my couch waiting to go to work, and I can watch this.
So obviously this is a 45-minute presentation, but again, the presentation that is available that he presented to our own group is available there, again, on their iPads whenever he or she wants. Okay, and then finally a 6th case. So we have a pretty big simulation center at McGill that the emergency medicine program uses quite significantly. The residents are, part of their role is to put on a simulation session on various topics, whether it's on airway or pediatrics or critical care. So there was a medical simulation done by one of the senior residents on trauma resuscitation. And she wanted to give out readings to all the residents to be prepared for the trauma session. And again, you can go to a textbook and read an entire textbook on trauma, but their learning objectives for this resident were very specific and very particular. So she sent out ahead of time particular readings, links to websites, and videos of how-tos and some indications of particular procedures that residents need to learn. So again, all of this now can be packaged in one course during for the residents to learn.
Sure. So we're told ahead of time that these readings will be available.
So again, this is on the McGill Emergency Medicine, the Grand Rounds course.
So this was the trauma simulation. So first of all, there is a number of articles that Dr. Turner made available to us. Just reviews of the management of brain injuries from trauma, for example. And there was also links to a number of videos that we could watch. These are on external sites. And then the last thing is there's a number of blogs, social media sites that the residents like to use, and they have very good summaries on different material. So for example, this one's on trauma in pregnant patients. And so there's a good overview that we were able to review for the simulation.
Okay, great. So those are 6 cases. I mean, again, as a pilot project to see how residents are using this and how the implementation was going. These are just sort of 6 ideas or 6 examples of how residents can obtain this information. So I'm going to leave it up now to those who are actually using it, and that's the residents, in terms of discussing in this last year what have been some of the benefits of implementing the iTunes U course during their training.
Yeah, so I think one of the big ones for me, and I know for a lot of the other residents, is the ability to show our patients what's happening or what's about to happen. The emergency department is very stressful. There's a lot going on. And I think it helps patients to visually see the procedure as to what we're going to do and how it's going to help them.
I think one of the things for me is in terms of education, I can give you an example that actually happened last week. I'm rotating right now through the pediatric intensive care unit, and these are very critically ill children, and we take our utmost care and utmost diligence to make sure the dosages are correct that we're giving them. Unlike adults, there are very specific dosages for children. They're based on their weight. For adults, the dosages are usually a kind of fixed dose that we know kind of off the top of our heads. So I started my rotation last week, and in the pediatric intensive care unit, there are actually 2 documents that go over very commonly used medications and the per kilogram dosages of these medications. I thought it would be an excellent idea to actually have them accessible on our phones because they are paper in the pediatric ICU. So I emailed Joel. I said, these are 2 really important articles, or really 2 important PDF documents that I think that residents would greatly benefit from. And then I went to work the next morning, 7 a.m. I look on my phone on iTunes U, and there are the 2 documents. And actually use the documents maybe 4 or 5 times throughout the day, prescribing medications to critically ill children. So I think it was a great example of how quickly the information can get put onto iTunes U, and at the same time, all of the residents had access to these documents that I thought were extremely important for our training and for treatment of our patients too.
For me, it's much more that this is a great repository of all relevant information that has been deemed to be relevant by the residents or perhaps Dr. Turner and whoever's managing the course. The main thing is all of the stuff that's on iTunes, that's on there, can be found either on the hospital local intranet, can be Googled, can be found on various resources. But the thing is, we know that like the ones that are on there are the ones that have been vetted for, at least by us or by Dr. Turner or other staff members, so that we know, hey, if we go in here, this is going to be the stuff that's sort of not necessarily cream of the crop, but at least these are ones that are recognized to be good, and it's all in one place.
Good. So we're just going to there's a couple questions coming on from the QA feed, so I'm just going to open up to you guys. So while watching videos, do you take notes? And if you do, how?
So, these are videos and maneuvers and things that we've learned throughout med school. So we have read the books, obviously, and we've gone through it. I think that reading a procedure like the Epilepsy maneuver versus seeing it is absolutely different. I think seeing it is a lot better. In terms of writing notes, for videos, I don't write notes, at least for procedures, but for those lectures that you saw, I definitely actually wrote notes on that exact lecture that we showed to you. So it depends on what the video is, but most of the time for procedures, it's kind of just getting comfortable with what you're seeing, how to actually do the procedure. But in terms of if it's at a lecture and there's great points to remember, I would write it down or maybe even type it up or even star it or something like that, I think.
And just on the side screen here, so iTunes U does have a built-in notes feature, so you can add notes as you're going along, things that you find important, and it will be left in that particular thing, and it's just for you to see in terms of your learning from those resources.
Next question, are those videos on the iPad or they're streaming? So actually, I'll just answer, they can be both. You could actually have a link to a website to stream it, or you can actually have it downloaded. It's a question of whether or not I upload the actual video itself to the iPad or whether or not it's just a link. Obviously, with massive amounts of videos, their iPads might get a little bit full, but then the resident has a choice of actually removing the video, but having a link to download at any time in the future. Next question, so how often do you refer to the social media sites? I think it's...
I can answer that question again. Again, one of the projects I'm looking at is how residents use, or how even medicine in general is using social media in terms of displaying information or gathering information even. I think there are several blogs that are pretty popular, especially in emergency medicine. Over the last couple of years, there's about 10 or 12 very highly reputable blogs that have their own standard of information, which means that the information that they post on the blogs are of a certain standard in terms of quality. How often we refer to them in terms of iTunes U? I would say not all too often. When the things like we're having a simulation day and there are very specific blogs towards that simulation, we would. But what do you think, Rohit?
I mean, yeah, I certainly refer to them more than once a day in terms of social media use. Not always through iTunes U, but yeah.
Yeah, in terms of our own learning, blogs are becoming very popular and very accessible and kind of user-friendly too. It's a lot easier looking at a blog and you can scroll down than opening up my big 4,000-page textbook and trying to find something. So I pretty much use it on the daily as well.
Yeah, I haven't used it as much, but there, as Martin and Ro has mentioned, there are some blogs that also have podcasts that are very, very renowned, at least in the emergency medicine field, where at least one of them, once a month they have like a 4-hour podcast, and you can chop it up and listen to it. So I do that when I'm riding my bike or taking the bus to work, and that's mostly of how I've been interacting with the social media side of things.
I think the way of the textbook, especially in medicine and in emergency medicine, is becoming more and more archaic. I hope there are no publishers in the audience. But when a textbook gets published, it is of material that is already at least 2 or 3 years old. And in emergency medicine, we need to know what just came out in the literature 2 months ago or last week. So textbooks are really not where residents are going to get their up-to-date, high-quality material. And blogs is, I think, one of the well-known emergency medicine educators from North America and around the world. We know that these are high-quality, up-to-date material, and they are provided on a monthly basis. So you know that you're getting up-to-date product, and it's of high quality. Okay, next question. If the material is publicly available, is the school concerned about giving up a competitive advantage? So in terms of publicly available, this is actually not publicly available. One of the main issues is this is a private course that I develop, each of those courses that I develop, and send a link directly to the resident. And once the resident clicks on it onto their iOS device, I have to allow or accept their joining into that course. So if you go to the iTunes U or iTunes app or website and you search on iTunes U, you will not find these. These are private courses, and so they're not actually publicly available to anyone. That's probably one of the benefits, is that it's only for the residents to be able to use, and it's not there are no privacy issues from that point of view. Next question is, what's the risk of the iTunes U site not being updated and presenting deprecated information? So I guess that's my role as the teacher, is to make sure that every few months or once a year I go through the site and I make sure that if there's new material that now has the sort of superseded the material that's already there, it's my role to remove the old material. And again, you cannot get that in any type of textbook. That textbook is printed, it's there. In fact, textbooks have websites where they actually post erratums or appendices of new material. So now you have two places. You have a textbook, and then you have to go to the website to see if there's anything new. So the whole point of iTunes U is if one of those articles is now no longer valid, I just remove it and put what is valid and what's new. How might the lessons learned from this pilot be applied to bring your own device projects in the health authorities? I'm not sure I understand. Well, I guess how are you going to be using this as a physician or a hospital? I'm not sure if I'm clear on the question. So I don't know if that person is here in the audience, but can clarify. Or if you hear me, you can maybe restate your question. So I'll go to the next one. Is the data stored on servers within Canada? That I'm going to have to ask Apple. I don't know. I guess the materials, once they're downloaded onto their iOS device. But where they're specifically stored, I wouldn't be able to tell you. That's more of an IT question that's beyond my physician or teacher or student topic. So I wouldn't be able to answer that question. All right, so just from that question, while there are more questions coming on, so what have you felt have been the challenges of implementing iTunes U and implementing these things?
So a recent example is at one of our hospitals, which is the big trauma center for Montreal. They recently started a new sort of organization of our resuscitation area where the doctors stand, where the nurses stand. And that's changed within the last month. And getting that onto iTunes U is kind of a challenge because we have to find the document, get it to Dr. Turner, upload it. So keeping on top of these protocols and knowing what's changing at the hospital level and translating that to the educators and the students, there's some delay in keeping on top of that can be a challenge.
I think for me, it's more of a general feeling of seeing your doctor using an iOS device in front of you. And I don't know how you guys would feel about that. I'm guessing in this room it's a little bit more accepting, but if you get someone who's not as tech savvy, let's say someone who's a bit older, maybe 70, 80 years old, and they see you looking at your phone, they might lose a bit of confidence in you. I think that's something that I may have felt a couple of times, but at the same time, the way that we are treating patients, the way that medical education is happening, everything is changing. And I think the more and more we use it, the more and more people are going to be comfortable with seeing us using it. And at the same time, we're using it for the good of the patient. We're getting the proper dose of the drug. We're getting the new hospital guidelines that are up to date. So in the end, really, it's for patient care, it's for patient benefit. But I think one of the challenges is that when you're taking your phone out and then they're giving you a little bit of an eye, like, does this doctor know what he's actually doing? Like, what kind of quack are you sending me to? But really, if you explain to the patient what's happening, like, listen, I'm looking at the most recent dosage based on this article that came out last week to help you. I think just a better communication with the patient will make them understand and accept what you're doing a little bit more.
I think for me, one of the main things as with any user-driven project, is adoption, right? Like for a long time, having fairly strong IT and tech background, I actually didn't really start using this for a long time. And one of the main reasons is, at least in the emergency department, there's computers all around. As I mentioned before, all this information and more are on computers. But if I'm at a computer already, well, why would I pull out, my iPhone or iPad to suddenly look this up? So finding the right message, finding the right ways to present these to residents. Hey, it can be useful in these circumstances. So running through some of those scenarios that we just did would be very, very helpful to drive more adoption earlier on. So that would be the challenge I see.
But I think too, like now the hospital is now going to force us to log in every time we want to look at a McGill library resource, which can slow us down a little bit sometimes. So to have it right at your fingertips, where you just have to punch in your own phone password to access the materials, is a lot faster. So that may push, I think, a few more people to use it.
And it's one of those things, like once people know more about it, that becomes a lot easier. Like, I didn't realize how useful it can be until, not too long ago. And once I saw it, it's like, wow, like, I'm going to, try to incorporate a lot more. But as with most things, change is always difficult. Once you get there, then you start seeing benefits.
So a quick question, so is the curation that you're doing today, it's basically net, right?
Yes.
And it's sort of unidirectional. So is there any ability for you to provide bidirectional feedback on the curated data that you're seeing within iTunes?
What do you mean by bidirectional?
Well, so for example, having the doctor's feedback into the material as they consume it, right? So it's like the prescription rates for these drugs are interesting, but in practice, over maybe a longer period of time, our experience has been falling, and for them to provide feedback to the
Well, I mean, I think that's a good question because you're talking about two different things. Hospital policies and drug formularies,
Yeah.
they take a very long time
Yeah.
to change.
Yeah.
So, and I know when I was a resident at the Children's Hospital, and you will back me up, I guarantee you, if you try to change a single dose to a nurse, they will slap you across the head. They take extreme ownership of their little patients, and they say, no, this is what the drug dosage is in this hospital. And sometimes it can be very frustrating. I mean, I know that when we were doing procedural sedation, I couldn't use some of the drugs that I normally would use. And they say, well, no, you can't because the hospital wouldn't allow it.
Right, but does the hospital have the ability to grab the feedback from?
That's probably at a P&T committee, the Pharmacy and Therapeutics Committee of each hospital. If there's a push, I know that in the adult hospital where I work, if there's a push to introduce a new medication or to change a dose or the way a medication is provided, we can absolutely go to those committees, provide the evidence of why this drug is better, and the pharmacists there will take it into effect and may change their policies and protocols, of which we all get a PDF email of a new drug that they're using, in which case I'll just add that on. But that's from a hospital policy, there are levels of committees that they have to go through. But if there's a new article that talks about a new, for example, a new drug or duration of therapy for a certain treatment, that I can just add on right away to, oh, here's a new article for you guys to read and consider sending this person home on 5 days of antibiotics instead of 10 days of antibiotics because this new article shows that there's no difference and you actually it's better.
And sort of along the similar lines too, is that there's no integration with the electronic medical health record. Right? So
That's my next slide after this, is that for sure, from what, if you look at research as to implementation of tablets in the hospitals, by far the strongest limitation is integration into the electronic medical record. We're not there yet. Because clearly, if you have to go to a computer to do your electronic input, and then you have your tablet, well, you're already on the computer, so maybe you're not going to use two devices.
Plus, when you need to be here, and so.
Yeah, exactly. So I think it is coming. We are actually, at my hospital, we're going to be becoming paperless in the next few months. We are actually testing tablets to have the electronic health record. And I know that actually the University of Ottawa, in the emergency room, they use tablets for they have their electronic health record on their tablets. So it has to be integrated in their mobile device to be able to use something like this as well as the material on a tablet.
Because I think the eventuality is that you have your EHR, you have your corpus of data, and then you have the data dynamically curated for the individual at point of care.
Yeah, I mean, it would be interesting to see. I think your question is like, are we prescribing more of drug A versus drug B? And this technology doesn't allow them to track this yet. It would have to come from the EMR software.
Yeah. And that real-time feedback at point of care systems approach obviously has massive potential. So, yeah.
Just curious from your viewpoint, being physicians, what do you see based on your code of ethics and various things you as physicians you're doing as part of your professional conduct? What would be your concerns with regards to privacy and security of information?
So, I mean, right now there's nothing on here that is patient related. This is all information that is educational. And we're sort of the same privacy regulations that we follow for any library material that we have access through McGill University.
Just an agile question, availability management is a practice in IT, but there's practice in security, CIA, confidentiality, integrity, availability. So the fact that you're the curator of this information and where it's hosted and to guarantee the integrity of that such that it's linked to the policies and processes at the hospital level.
Mhm.
So if someone goes in and messes with that information and an incorrect dose gets administered, you're going to have to follow the breadcrumbs back to what are the integrity issues and what are the availability and confidentiality issues that were put in place to have access to provide the update for that information. And as a side one, having lived in IT for a lot more years than you guys figure out, is the data gets old.
Mhm.
And you've got an amazing repository here that's constantly getting added to. And as we know in the knowledge management database perspective in enterprise IT, that stuff starts to get stale and you can't find the good stuff because you've got reams and reams of the old stuff which starts dragging down the new stuff.
Yeah.
So now you've got performance issues, you've got to look at the whole capacity.
We have the same terminology when we review articles, garbage in, garbage out. So if the information is not useful, then what they're going to learn is not going to be useful. But you're right. I think one of the challenges is that I'll add up is that as the material becomes even bigger, it's also knowing what's in the courses. And so, for example, Wayne may not have been using it for a while because he may not have known, oh, I did not know that this procedure was on my iPhone. I didn't know that the policies and protocols of this. So, they have to be made aware of what's there, and I think that's through what we call knowledge translation, translating what's there and making sure they are aware of it. But my role is, as you mentioned, is to constantly find out what is old and what is no longer useful and make sure that's removed. In fact, I just did that yesterday before this talk. There was a couple of policies from one of the hospitals of a certain drug that's used for a certain type of condition. The policy was outdated. And so I just removed it because I don't want them to learn the wrong drug to give to that patient because it's now outdated.
And I think at the same time, this is not our brain. So we do know medicine. So I think you know, like I'm not going to say, okay, I'm going to prescribe this medication and write it out word by word. I'm going to think about it. And there's also safeguards in the hospital, right? We have the pharmacist who's overlooking the prescriptions that we're making. We have the nurses who are giving the medication. We also have our attending physicians that we go over the case with and we say this is the medication that we're given. So I understand that even if there are mistakes or someone goes in and hacks and changes the medication dose, heaven forbid, I think there are safeguards in place. And again, this is just kind of reminder, refresher, education, rather than I'm going to use this word for word to prescribe this medication. So it is a point to bring up, but at the same time, there are safeguards in place to kind of avoid any errors like that happening.
And I would say that, yes, I do recognize the potential, but I would say the potential for a learner to prescribe the wrong medication, the wrong dose is much higher if there isn't a knowledge that resource is available. Because I'm going to say, yeah, I'm sure it was this drug and I think it was this dose. And yeah, there are cracks that you can get slip through, and that drug might be given to the patient. But if there is a resource of a policy and protocol that is available that they can access to, there's another safeguard. But I understand if someone can go in and change the doses, it is a potential.
Joel, actually, sorry, a quick question. Is there some way, like within the iTunes U, maybe the Apple rep could respond as well, like that I can say, hey, you know, this document was good or was not good? Is there some way, like a thumbs up, thumbs down kind of thing?
I think just a direct email to me to go in and take a look at it. There was a hand. Yep.
Yeah, so Joe Harrison, I work at the Faculty of Medicine at the University of Ottawa. One of the questions, so what I'm seeing here is it's a lot of referential learning. It's references, it's things that have been pre-existing. Do you guys have any plans to maybe move towards more of an active learning, more of a, how do you measure like what people are, like your residents are learning? We're working on a project with pediatrics at CHIO, and that was one of their big questions is we want to make sure the residents are learning what they're supposed to be learning, and we want to be able to measure that and test against that to make sure that they're doing the right kind of thing. It's good to have this kind of material, and I agree it's a great step in one direction. But like, what's the
how do you know it's
step?
working?
Yeah, how do you know it's working? How do you know the residents are actually reading this stuff, learning this stuff, and putting it in practice?
I think from my perspective, one of the examples I can give you is the simulation. So we have simulation pre-readings, and it's really easy to tell if someone read or not. When you have your whole resident group watching you, and you're kind of managing a mannequin, and I'm asking Rohit for this medication, and what do you think the diagnosis is? rather than someone who's kind of on the ball. They know exactly what to do. They went through the guidelines, they went through the algorithms, and you can really tell there are evaluations too, and there's feedback that we constantly have. So we constantly have feedback after each of the simulation sessions. In terms of the other applications for the app, you're right. It might be a little bit more difficult because we do have evaluations after each of our emergency department shifts. But whether he or she got the information from Tintinelli's, which is one of our emergency medicine textbooks, versus here, it's impossible to tell. But it's just the way that the resident is functioning in the emergency department. So if anything, I think this may allow us to be a little bit more quick in terms of prescribing and see more patients per hour per se. Not really sure, but it will be something that may be a bit of a difficulty, but something that we challenge that.
So do you see this more as coming, I'm referring to what we're seeing in the market in terms of this whole sense of openness and making things available to a wide range of people. And we're seeing things pop up like Coursera, the Khan Academy, EDX. I mean, EDX is a great example that McGill participates in for Comp Sci, where they kind of contribute to the body of knowledge that's out there, and it's curated by professionals like yourselves. Do you see medicine kind of going in that route to make things more open, to curate more content? So, for example, if you're in emergency medicine, you can get the best learning available, for example, in North America or maybe in the world. So people go there for the resource, and they know that this is the best stuff because we have all these specialists that are recognized globally that are curating this content and making it available open for people to be able to learn, and which makes everybody happy.
I'm sorry to interrupt, but we need to move on to the next session, so we'll have to carry on the discussion after this.
Okay, so anyway, I'm glad we had a lot of questions. A couple of questions here I didn't get to, but I mean, clearly, just as you see, the amount of information that residents have is it's overwhelming sometimes at times to get that access to that information. And it's dispersed everywhere. There's various logins, various passwords. So again, it breaks down on the efficiency issue. There's, mobile learning is basically totally widespread. Every single resident, every single medical student, almost every staff has a mobile device that they use. And so this, iTunes U has become sort of this one-stop shop for the residents to use as a platform to access clinically high-quality material that will help them, I guess, with their patients as well as with their learning. And with that, I thank you very much for your attention.